Assalamu alaikum, my name is Khaled Hammoudeh. I'm going to be covering part 2 of this anatomy crash course. Now, these are the lectures that I'm going to be covering. I believe after these lectures, the rest of the anatomy MSK is going to be really easy to go through. So now, starting off with hand 1 and hand 2. Hand 1, I'm going to be covering the fascias and the joints and the muscles of the hand, and in hand 2, I'm going to be covering the vessels of the hand. So now, starting off with the radiocarpal joint. So the radiocarpal joint, also known as the wrist joint, is a condyloid joint and is formed proximally by the radius and the articular disc. Notice that I did not mention the ulna because the ulna does not have any articulation with the carpal bones. It's separated by the articular disc, which actually has the actual articulation with the carpal bones. Distally, it is formed by the scaphoid, lunate, and triquetrum, which has the articulation with the radius and the articular disc. Now you have two important collateral ligaments which helps with stabilizing the wrist joint, which are the radial collateral ligament and the ulnar collateral ligament. The radial comes from the radius and the ulnar comes from the ulna. So now that we know what is the radiocarpal joint, now let's talk about the movements of this wrist joint. You have flexor carpi ulnaris and flexor carpi radialis for the flexion of the wrist. You also have the flexor digitorum superficialis, which assist in this movement. However, it's not the main movement. That's why I have the other two in green and the last one is in white. For the extension of the wrist, you have the extensor carpi ulnaris, extensor carpi radialis longus and brevis, which allows for the extension of the hand. Same idea here for the extensor digitorum. It assists it, however, it's not the main movement. Now for the abduction and adduction of the wrist, you have flexor carpi radialis, extensor carpi radialis longus and brevis. These are for the abduction of the wrist, also known as the radial deviation. For adduction of the wrist, you'll have flexor carpi ulnaris and extensor carpi ulnaris, which is for the ulnar deviation. Now that we finished the radiocarpal joint, now we're going to start talking about the carpometacarpal joints. So we're basically moving distally. We just finished this area, now we're going to talk about this area. So the carpometacarpal joints, all of them except the first digit are plane joints, and these plane joints allows for little movement. However, for the first carpometacarpal joint, it's a saddle joint. This saddle joint is formed between the first metacarpal bone and the trapezium carpal bone. And we know from F&D, saddle joint allows for more movement than plane joint. It allows for abduction, adduction, opposition, and reposition. Now, metacarpal phalangeal joints. Metacarpal phalangeal joints allow for flexion, extension, abduction, adduction, and circumduction because they're condyloid joint. Now, you might be asking yourself, what is circumduction? Circumduction is the movement that allows for all these four movements. So, if you read circumduction, know that there is flexion, extension, abduction, and adduction. Now, there's also another part for metacarpal phalangeal joints, that sometimes these joints can have a sesamoid bone with them. Most of the time, it's in the first metacarpal phalangeal joint, and this sesamoid bone is embedded within the flexor pollicis brevis muscle. Obviously for the first metacarpal phalangeal joint. Okay, now finally the most distal joint of the hand, it's the interphalangeal joints. Now the interphalangeal joints for the second and the third and the fourth and the fifth digit are gonna have three phalanges, and because we have three phalanges, that means we're gonna have two interphalangeal joints. So we're gonna have a proximal one and a distal one, and for the thumb or the first digit, you're going to have two phalanges, which means you're going to end up with one interphalangeal joint. Now you might be asking yourself, how are these hinge joints, even though they look quite similar to the metacarpal phalangeal joints? These joints have a very strong collateral ligaments, preventing them to even have any chance to do any abduction, adduction, which keeps it as a hinge joint, allowing only flexion and extension. Now that we finished the joints, now we're going to talk about the fascias of the hand. So the fascia of the hand, you have a superficial fascia and a deep fascia. The deep fascia is made out of the palmar aponeurosis. Now this palmar aponeurosis is located between the thenar and the hyperthenar compartments. Now you might not know what these are right now, however we're going to mention them later on once we get to the muscles. they're continuous with the palmar longus muscle. So this is really important to know that it's continuous with the palmaris longus, and it distally blends in with the fibrous flexor sheath. So what's the point of this palmar aponeurosis? Is for the protection of the superficial palmar arch, which is an artery, the digital nerves, obviously the nerves, and the flexor tendons. Now that we know what's the what do you call it again? Palmar aponeurosis. Now we're going to talk about the Dupuytren's contracture. So what is Dupuytren's contracture? It's when this palmar aponeurosis becomes shortened and it becomes more fibrous. This is going to pull onto the fourth metacarpal phalangeal joints. So no, any pulling to the fourth metacarpal phalangeal joints, that means it's a Dupuytren's contracture. And to the metacarpal phalangeal joint and the proximal interphalangeal joints. Now sometimes it can be for the pinky joint, for the pinky finger. However, most of the time it's for the fourth finger, which is the ring finger. Also know that the distal interphalangeal joints are not involved. It's only the metacarpal phalangeal joints and the proximal interphalangeal joints. And this also happens more commonly in men older than 50. Okay, now coming to the flexor retiniculum. Now the flexor retiniculum is also a thick fibrous band at the wrist joint, which forms the roof of the carpal tunnel. Now we're gonna go to the carpal tunnel soon. However, just know that the flexor retiniculum is gonna form the roof. Laterally of the flexor retiniculum, you're gonna have the scaphoid and the trapezium, which is gonna be somewhere around here, and medially you're gonna have the pisiform and the hook of Hammoudeh. So with these four carpal bones, you're gonna have the attachments for the you're gonna have the formation of the flexor retiniculum. Now let's talk about carpal tunnel. So the carpal tunnel is mostly made out of the carpal bones, specifically the lunate, because it makes up the most of the formation of the carpal tunnel. And we have the roof of the carpal tunnel, which is made out of the flexor retiniculum. Now, what are the contents of the carpal tunnel? The most important one, and you really need to know this, is the median nerve, because you're gonna have a lot of clinical scenarios regarding this nerve, regarding this nerve being in the carpal tunnel. You'll also have 9 flexor tendons. You're gonna have 4 distal superficialis and 4 distal profundus, because they're going to go towards the 4 digits, which is the second, third, and the fourth and the fifth digit. And lastly, you're gonna have the last tendon, which is going to be the flexor pollicis longus. Now, clinically, this can cause a median nerve compression if you have carpal tunnel syndrome. Just forget about this right now. I'm gonna explain it better in the upcoming slides. Now, we're gonna talk about the flexor synovial sheaths. Now, the flexor synovial sheaths allow to make movement in the hand a lot more smoother and easier. And it's at the wrist joint, you'll have 3 synovial sheaths. And once you go more towards the digits of the hand, you're gonna have the ulnar bursa and the radial bursa. Now, the radial bursa is only gonna go towards the thumb, and the ulnar bursa is gonna make up the synovial sheaths, the 4 digital synovial sheaths of the finger. And something important that I need you to know, that the thumb and the little fingers synovial sheaths are continuous with the forearm, which is going to be important to know right now. But before I talk about that, let's talk about the synovial cyst. Synovial cyst, any inflammation in the synovial sheaths is going to cause a synovial cyst, as you can see here in the photos. Now, for the hand infections, if you have a hand infection in the synovial sheath, specifically in the pinky or the thumb, you're gonna have an infection spreading, which is gonna spread towards the forearm through the ulnar bursa from the pinky and the radial bursa through the thumb, which is gonna cause a case called, I think, phlegmoma. Here's the writings of everything that I just said. I just want to confirm. Yes, it's called phlegmona. Now let's talk about the long flexor tendons. So now you have 2 long flexor tendons. You have the flexor digitorum superficialis tendon, which is for the main function of it is for the flexing of the proximal interphalangeal joints. An important thing that I want you to focus on here is that the flexor superficialis is gonna run through the digit until it reaches the proximal interphalangeal joint, and is gonna then start going laterally. However, for the flexor digitorum profundus, is gonna pierce through the superficialis tendon, the flexor digitorum superficialis tendon, and this is gonna allow for the flexion of the distal interphalangeal joint. Now let's talk about the movements of the interphalangeal joints. So what allows for flexion? We just covered these. The flexor digitorum superficialis is gonna allow for the PIP joints to flex, and the flexor digitorum profundus is going to allow for the DIP joints to flex. Now for the extension, you have multiple muscles that are going to allow for the extension of the interphalangeal joints. Some of them you might know them right now, some of them you might not know, however we're going to cover them just in a bit. You have the extensor digitorum, extensor indicis, and extensor digiti minimi, which you know from part 1. And then you have the lumbrical muscles and the interosseous muscles. Now, before we talk about the muscles, I want to mention an important clinical case, which is called the malate finger. This malate finger happens from a forced flexion of the distal interphalangeal joint. Once you have this forced flexion, it's going to rip your extensor digitorum tendon, which is going to end up with your finger looking like a mallet. That's why it's called a malate finger. And obviously, once your extensor digitorum tendon is basically ripped or ruptured, it's going to cause the inability to extend your DIP joints. So now we're going to come to the muscles of the hand. We finished talking about the fascia, and we finished talking about the joints of the hand. Now, starting off with the thenar muscles. The thenar muscles are the muscles of the thumb. So that means the muscles that are going to be in the thenar compartment are going to be the flexor pollicis brevis, abductor pollicis brevis, and the apponens pollicis. All these muscles are innervated by the recurrent branch of the median nerve. You might not know this right now, but however, when we mention when we talk about the vessels of the hand, we're gonna get to know this. Here are the images of the muscles of the thenar compartment. You can see go through these later. Now we're gonna talk about the adductor pollicis muscles. They're also for the thumb, however, they're not part of the thenar compartment. The adductor pollicis muscle has two heads. It has an oblique head and a transverse head. And it's also innervated by the deep branch of the ulnar nerve. So not the median nerve, by the ulnar nerve. So now we're going to talk about the hypothenar muscles. So we know the thenar muscles are for the thumb. The hypothenar are going to be for the pinky, the little finger. So you're going to have three muscles for the hypothenar muscles. You're going to have the flexor digiti minimi brevis, the abductor digiti minimi, and the apponens digiti minimi. These three muscles are for the hypothenar compartment. They're also innervated by the deep branch of the ulnar nerve. Now, this muscle is not that high yield whatsoever. It was not even in the slides, it was just in the table that Dr. Elena had. However, I added it for the sake of completion. So, the palmaris brevis is for the sake of the wrinkling skin of the medial side of the palm, and is innervated by the ulnar nerve. Now, let's start talking about more deeper muscles in the hand. You have the lumbrical muscles. The hand contains 4 lumbrical muscles that originate from the tendon of the flexor digitorum profundus. Now, you can think of these 4 lumbrical muscles, they can be divided into 2 compartments. A radial compartment and an ulnar compartment. They're not really compartments, but that's like a way that is easier for me to memorize it. So, you have the radial side, which is near the thumb, which is going to be supplied by the median nerve, and you can see here, they're all like unipinnate. And in the ulnar compartment, more medially near the pinky, or like it's actually part of the pinky, is supplied by the ulnar nerve, and they're bipinnate, not unipinnate. Now, these lumbrical muscles allow for a Z movement. Now, if you don't know what's a Z movement, try looking at these. Try flexing your metacarpal phalangeal joints and extending your interphalangeal joints. Once you do this, you're going to notice you have a Z movement. And obviously, this movement is also with the help of the interosseous muscles, which we're about to cover right now. So what's the opposite of Z movement? If you try try flexing your metacarpal phalangeal joint and flexing your interphalangeal joint, you're going to have a claw hand. That basically tells you that an issue with your interosseous muscles and your lumbricals is going to cause a claw hand. Now you have the palmar interosseous muscles. We have 2 parts. We have a palmar and a dorsal. So the palmar interosseous muscles, you have three of them. Now you must be thinking, why do you have 3, not 4? The palmar interosseous muscles has a main function of adduction of the fingers, of the digits. However, you need a midline to allow for adduction of the digits, and that midline is going to be your middle finger. So if the middle finger is the midline, it does not need palmar interosseous muscles to do adduction, because it's already it's basically always in adduction, you could say, except if you abducted, obviously. And so that means the 3 fingers that are going to have the palmar interosseous muscles are the 2nd and the 4th and the 5th digit. These muscles are also innervated by the deep branch of the ulnar nerve. Now for the dorsal interosseous muscles, you'll have 4 muscles. And these muscles are going to allow the opposite of palmar, which is the abduction of the fingers. And they're also deeper than the palmar interosseous muscles, and they're innervated by the deep branch of the ulnar nerve. Now you can see here that the dorsal interosseous muscles are, like, you could say, bipinnate. You have 2 muscles in each one. This can tell you that abduction is stronger than adduction. Even if you try it on your hand right now, if your hands are abducted, it would be harder for you to like force them to adduct, rather than if you have adduction, if your fingers are adducted and you try forcing them to be abducted. And this is the table that Dr. Elena added. I doubt that you need to know the origin and insertions, however I added it for the sake of completion. And let's start with questions for hand 1. So a man injures his wrist on a broken glass. Which of the following structures entering the palm superficial to the flexor reticulum may be damaged? So what you basically do here, we know the contents in the carpal tunnel, because we're talking about the flexor reticulum. So underneath it, you're going to have the carpal tunnel. So you pick anything that's not part of the contents of the flexor of the carpal tunnel, which is the ulnar artery and the ulnar nerve. They're not part of the carpal tunnel. Next question. While going up for a rebound, a basketball player jams her middle finger against the ball. Against the ball, she experiences severe pain, and the trainer notes that she is no longer able to extend her distal phalanx. So what allows for the extension of the distal phalanx? It's going to be B. It's a pretty easy question. There is someone who can't grip things and has atrophy in his thenar muscles. Which of the following nerve is compressed? We just said earlier that the nerve that supplies the thenar compartment is the median nerve, or also recurrent branch of the median nerve. However, we're going to talk about that just now in hand 2. A 50-year-old man has a ring finger and part of his small fingers appearing as if they're being pulled down with a thickened skin. What is the most likely diagnosis? So basically, ring finger is your 4th finger, and a part of his small finger, so the 5th finger, they're being pulled down. And we said earlier, pulling to your metacarpal phalangeal joints and proximal interphalangeal joint of the 4th finger, it means Dupuytren's contracture. Okay, now let's start with hand 2. So hand 2, we're going to talk about the nerves and the arteries and the veins of the hand, starting off with the dermatomes of the hand. For the dermatomes, all you need to know is that C6 is for the thumb, C7 is for the middle finger, and C8 is for the little finger, as you can see here in this photo. And now we're going to talk about the 3 nerves, the 3 most important nerves, the median nerve and the ulnar nerve and the radial nerve. Starting off with the median nerve, we already know that the median nerve runs through the carpal tunnel. And this median nerve, after it runs through the carpal tunnel, is going to give off 2 branches. It's going to give off the recurrent branch of the median nerve and the digital branch of the median nerve. The recurrent branch of the median nerve is going to supply the thenar compartments. Now you might be confused about the digital branch, because in the lecture it was mentioned as a more proximal branch. However, I searched it up and it was the digital branch. And I think it's important to know why it's a digital branch, and you'll just know why now later. However, the digital branch supplies the first and the second lubrical muscles. Now, we already talked about the motor innervation. Now, let's talk about the cutaneous innervation. So, the cutaneous innervation, the first branch is going to be the digital nerve. The same nerve that supplies the first and second lubricals is also going to be the nerve that supplies the skin of the lateral 3.5 digits, the palmar surface of the skin. So, the thumb and the index finger and the middle finger and half of the ring finger are gonna be for the skin innervation for the digital nerve. And it's also gonna supply the nail beds of the lateral 3.5 digits, the dorsal surface, obviously. And another branch that you're going to have for the cutaneous innervation, you're going to have the palmar branch. This palmar branch is going to innervate the skin of the palm. However, what you need to know, and it's going to come in a lot of clinical scenarios, is that the palmar branch does not run through the carpal tunnel. It goes superficial. So if you get a patient that has carpal tunnel syndrome, expect him to still have skin sensations in his palm. Now, we're going to talk about two types of injuries of the median nerve. You can have a proximal injury and a distal injury. Now, for the proximal injury, this injury comes from a fracture in the supracondylar part of the humerus. This fracture is going to cause benediction in the hand, where you're going to have loss of thumb opposition, weak thumb abduction, and loss of flexion of the index and the middle finger. So, if you ask the patient to try doing a fist, he won't be able to flex his first three fingers. However, he'll be able to still flex his fourth and fifth digit, because he'll still have the flexor carpi ulnaris and the flexor digitorum profundus, because they have the innervation of the ulnar nerve and not the median nerve. Now, once you go more distally, if you have an injury in your distal part of the median nerve, you're gonna have carpal tunnel syndrome. This carpal tunnel syndrome happens from a compression of the median nerve in the carpal tunnel, and it can happen either from a swelling or repetitive movements, or, really important to know here, lunate dislocation. You can see here, lunate dislocation is going to cause compression to the median nerve. Now, what does this carpal tunnel syndrome cause? It's going to cause loss of thumb opposition. So your hand is going to look like this, or it's also called as ape hand. And other things that can happen is going to be numbness in your lateral 3.5 digits. However, your palm sensation is going to be spared because the palmar cutaneous branch passes superficial to the carpal tunnel, and it does not run through it. Now, to test for this median nerve, to see if the median nerve is functioning or not, you're going to ask the patient to hold a piece of paper between his thumb and any of the other fingers. If the patient cannot do that, that means he lost his opposition fully. Now, why did we not ask about the flexion of the thumb or the abduction of the thumb? Because these muscles can also be done by other muscles, which is by the abductor pollicis longus, which is innervated by the radial nerve, and it allows for weak abduction. And you'll also have the flexor pollicis longus, which is innervated by the medial nerve. However, it's innervated by the proximal part of the medial nerve and not the distal part of the medial nerve. Now, sometimes the deep head of the flexor pollicis brevis is innervated by the ulnar nerve. However, I don't think that's really important to know. Okay, now let's start talking about the ulnar nerve. Now, the ulnar nerve enters the hand by passing superficial to the flexor retinaculum. So that means it runs superficial to the carpal tunnel. Now, it runs lateral to the pisiform carpal bone and medial to the hook of Hammoudeh. So it's going to be somewhere around here. You can see it here anyway. Once it runs between them, it runs through a canal called Guyon's canal. So once you read Guyon's canal, just know that they're talking about the ulnar nerve. Now, the ulnar nerve has motor innervations and cutaneous innervation. For the motor innervation, you have two branches. You have a superficial branch and a deep branch. For the superficial branch, it's going to divide into palmar digital nerves to the 1.5 digits. So the 1.5 digits are going to be half of the ring finger, the medial half of the ring finger, and the pinky finger, the little finger. Now, for the deep branch is really important because it supplies many of the muscles of the hand, being the hypothenar, 1 adductor pollicis muscle, 3 palmar interosseous, 4 dorsal interosseous, and 2 medial lumbricals. For the cutaneous innervation, you have two branches. You have the palmar cutaneous nerve and the dorsal cutaneous nerve. Now, again, same idea as the median nerve, yes. You're going to have two parts, two injuries, a proximal injury and a medial injury. Now, for the proximal injury, it's going to be a fracture to the medial epicondyle fracture, because the ulnar nerve runs around the medial epicondyle. So a fracture in that area is going to cause an injury to the ulnar nerve. Now, this proximal injury is going to cause flexion weakness, radial deviation. Because how will you, now radial deviation might not make sense, because how is like ulnar nerve and radial deviation intercorrelated? So basically, because you have an injury to your ulnar nerve, you lose ulnar deviation. So your hand is going to stay as in the radial deviation position, and it's going to also cause claw hand, because paralysis of the third and fourth lubricants, and also, by the way, the interosseous muscles is going to cause claw hand because you won't be able to extend your interphalangeal muscles. Basically, just from hand 1 is the opposite of benediction. Now, the distal injury of the ulnar nerve is going to be from a hamate bone fracture. If you have a hamate bone fracture, it's going to be also called Guy's canal syndrome. However, that was not mentioned a lot. This is going to cause claw hand and loss of skin sensations of the digits 1.5. And to test this, you're going to ask the patient to hold between a piece of paper between his index finger and middle finger to see if his adduction is going to work. And if the patient cannot do that, that means he has weaknesses in his interosseous muscles. Now, something that I would like you to notice is that in the median nerve and the ulnar nerve, the proximal injury is basically the same as the distal injuries, but with more issues. So if someone has an issue in his proximal part of his median nerve or ulnar nerve, he's going to have the same issues as if he had for the distal nerve. Now let's start talking about the radial nerve. We just finished for the median and the ulnar nerve. Now we're going to start talking about the last important nerve, which is the radial nerve. So you're going to have two branches for the radial nerve. You're going to have a superficial branch and the deep branch. Now, from earlier lectures, we know that the superficial branch is located at the snuff box, the superficial branch of the radial nerve, not the radial nerve, because so many people get that confused that they think the radial nerve is at the snuff box. However, it's the superficial branch. And this superficial branch is for the skin on the posterior surface of the lateral 3.5 fingers. For the deep branch supplies all extensor forearm muscle except two, which are the brachioradialis and the carpioradialis longus. They're also innervated by the radial nerve, however, not by the deep branch. They're innervated by the radial nerve itself. Now, injuries to the I wrote here ulnar nerve. I'll fix that later. However, it's radial nerve, not ulnar nerve. Injuries to the radial nerve is going to cause a wrist drop. So a wrist drop means that the patient won't be able to extend his wrist. And that's basically the most important thing that you need to know about the injuries to the radial nerve, that the patient is going to remain at the flexed metacarpal phalangeal joints. His metacarpal phalangeal joint is going to stay flexed and not extended. Weak extension of the interphalangeal joints may still occur. So that means I'll explain this better here. So to test if there's a radial nerve injury, the patient, you put your hand on the patient's digits and then you ask him to start trying to extend. And if you do see the extensor digitorum tendons, that means that the patient's radial nerve is working fine. However, if you can't see them, that means that the patient's radial nerve is not working fine. Why is that important to do? Why did you have to add pressure on his finger? Because if you don't add pressure, the patient will still be able to extend his interphalangeal joints, because the interphalangeal joints are extended by the help of the ulnar nerve, by the interosseous muscles. And that's basically the most important thing you need to know. This picture honestly helped me memorize issues and with the nerves. Dr. Comma, that means drop wrist is from doctor. Then the CU, claw hand ulnar nerve, and MA is for median nerve and ape hand. I mean, you don't need to memorize this obviously, but this is a way to have it memorized easier. So now, lastly, for the innervations of the hand, you have the cutaneous innervations of the hand. So from all the nerves that we just talked about, this should all make sense by now. However, I want you to focus on this coin-shaped area between your first and second digit. This area, if you have an issue with your radial nerve, you could still have sensations in that specific area because there is nerves overlapping in that area. That's what I wanted to mention about this line. However, you should know all of these from what we just talked about earlier. Now let's start talking about the arteries of the hand. First of all, you have the radial artery. The radial artery enters the palm of the anatomical snuff box by passing between the heads of the first dorsal interosseous muscle. So I want you to see here the first dorsal interosseous muscle, how you have the adductor muscles covering it. However, the first dorsal interosseous muscle, you're going to have a space between them. This space between them, you're going to have the radial artery running through them. Now, something important you need to know about the radial artery is going to anastomose with the ulnar artery, with the deep branch of the ulnar artery, and this anastomosis is going to form an arc called the deep palmar arc. This deep palmar arc is formed by the anastomosis of the deep branch of the ulnar artery and the radial artery. The other branches that come from the radial artery, you can see here, you have the what do you call it again? You have the radialis indicis artery, and you also have the princeps pollicis artery. I tried finding the dorsal digital artery, however, I could not find it anywhere, even online. It was not like any specific artery. Now, to talk more about the deep palmar arc, we know that it's made up of two arteries, the radial artery and the deep branch of the ulnar artery. This palmar arch is going to give rise to the palmar metacarpal arteries, and this is really important to know because you're going to have another arch which is called the superficial palmar arch. However, it won't give rise to the palmar metacarpal arteries. I'd like to mention that it lies on the interosseous muscles, deep to the long flexor tendons. Now you have the ulnar artery. Now the ulnar artery is going to terminate by giving a deep palmar branch, and then it's going to continue as the superficial palmar arch. So basically, we're going to talk about the superficial palmar arch better, but what you need to know about the ulnar artery, that it's going to terminate giving again the deep palmar branch, and then it is going to continue later on, as you can see here, as the superficial palmar arch. Now the superficial palmar arch is mainly formed by the ulnar artery, which we just said earlier, and it's going to anastomose with the superficial palmar branch of the radial artery. So you're going to have another anastomosis, one deep one and one superficial one. Now this superficial palmar branch of this superficial palmar arch is going to give rise to two important arteries. You're going to, first of all, if you follow it over here, it's going to make a lot more sense. You're going to have here the common palmar digital arteries, and then these common palmar digital arteries are going to give off the proper palmar digital arteries, and these arteries lie deeper and immediately deep to the palmar aponeurosis. This arch is going to lie more superficial, not deeper, and is going to lie immediately to the palmar aponeurosis, the deep fascia. Now we're going to talk about the disease regarding these arteries. You have the Raynaud's disease, Raynaud's disease. So Raynaud's disease is basically what you need to know in cold temperature or any emotional stress. You can have a reduced blood flow, and this reduced blood flow in your finger is going to make your fingers look more paler. Once you have these paler fingers, you should know that you have reduced blood flow in there, and this is called Raynaud's disease. This happens most of the time in young females and in individuals exposed to repetitive vibrating tools. Now that we finished the arteries, now let's talk about the veins of the hand. Now, we know from earlier lectures that the veins of the hand, you have two main veins in the upper limb. You have the cephalic and the basilic vein. Cephalic being lateral and basilic being the medial one. Now, these two originate from the veins in the hand, which the veins in the hand collectively are called the dorsal venous network. This dorsal venous network is going to give off two veins. If you go laterally, it's going to give the cephalic vein, and if you go medially, you're going to have the basilic vein. Now, lastly, let's talk about the lymphatics and the disease and infection. So basically, for the lymphatics, for the lateral hand lymphatics is going to follow the cephalic vein, and once it follows the lateral side, it's going to go all the way up to your apical region and to the axillary node. However, for the medial hand, it's going to follow the basilic vein to the cubital, like the cubital area, which is at the elbow, or it's also called the supratrochlear area. Then it's going to later on goes to the axillary nodes. Now, infections may spread there, and it's going to cause lymphadenitis. And hand infections commonly cause edema on the dorsum of the hand. Okay, so now for questions for hand 2. During an accident, the artery located lateral to the pisiform bone was severed. Which of the following arteries is most likely injured? So lateral to the pisiform bone, you're going to have the ulnar artery. It's just the same as the idea for the ulnar nerve being in the Guyon's canal. To remove an object below the nail of the 5th digit. So below the nail of the 5th digit, that means it's going to be which branch of the ulnar nerve? It's going to be the superficial branch of the ulnar nerve. Dislocation in the wrist led to compression of the median nerve. Which of the following bones is most likely compressing the nerve? So we know in carpal tunnel syndrome, which dislocation of which carpal bone is going to cause it? Is going to be the lunate bone. And lastly, interruption of the median nerve in the cubital fossa affects which of the following movements of the thumb? So interruption of the median nerve in the cubital fossa, so it's more proximal, is going to cause an issue with flexion and opposition. Okay, now for upper limb nerve injuries, this one's going to be a lot faster and a lot easier than hand 1 and hand 2, because most of it, actually all of it I could say, is repeated from previous lectures, especially from hand 1 and hand 2. Okay, starting off, let's talk about the brachial plexus, because these are really important to know. Have these all memorized. I don't have to go read all of them, just have these memorized before we go into the lectures, into the injuries. So starting off with the upper brachial palsy. The upper brachial palsy is an injury to your upper root of your brachial plexus, specifically your C5 and C6, which form your superior trunk. And this happens when there's an excessive increase angle between the neck and the shoulder. This increase is always going to injure your upper roots and is going to injure 3 main nerves: your axillary, your suprascapular, and your musculocutaneous nerve. Now, once a person has upper brachial palsy, he's going to have a clinical sign called waiter's step. Waiter's step is a combination of adducted shoulder, medially rotated arm, and extended elbow, which is going to look just something like this. Now that we have upper brachial palsy done, now let's talk about the lower brachial palsy. Now, what causes lower brachial palsy is going to be an extension or an extensive pulling of the upper limb, either from falling down and holding into an object, or during birth if the doctor pulls onto the baby's hand. This is going to cause an injury to your lower brachial plexus, specifically your C8 to T1 roots. Now, what can this cause? This can cause Horner syndrome. Horner syndrome is a combination of ptosis, meiosis, and anhidrosis. You can know from here, ptosis is drooping of the eyelids, meiosis is constricting pupil, and anhidrosis is loss of sweating on the face. Now, another sign is going to be a complete claw hand. Just know, in lower brachial palsy, you can have a complete claw hand. And this is everything that I wrote here in words. Okay, now injury to your long thoracic nerve. Injury to the long thoracic nerve is going to give us something called winged scapula. This winged scapula is going to happen due to the paralysis of the serratus anterior. How can this happen? How can someone get an injury to their long thoracic nerve? It can happen either to the stabbing in the lateral chest or in a radical mastectomy, like during surgery. The winging of the scapula occurs when the medial border protrudes away from the thoracic wall. So you can see here, an injury is you can see the protrusion of the scapula protruding away from the thoracic wall. And you can see this mostly when someone is doing push-ups or is someone pushing against a wall. You can see this more. So what happens? Arm abduction above the horizontal line. So the serratus anterior, one of its function is abduction over I think it was the 115 degrees. So if there's a paralysis to the serratus anterior, the person won't be able to abduct further than that. Okay, now that we finished the long thoracic nerve, now we're going to come to the injury to the suprascapular. Now, once you see suprascapular nerve, know there's going to be an issue with your supraspinatus and your infraspinatus. And an injury to your supraspinatus is going to cause us not to be able to abduct from our 0 to 15 degrees. So initiation of arm abduction is fully gone. And an injury to your infraspinatus is going to cause a weakness in your lateral rotation. And that's basically it for suprascapular nerve. Now, an injury to the subscapular now this time is gonna cause paralysis of 2 muscles, your subscapular and your teres major muscles, your teres major muscle, and these two is gonna cause an injury to your is gonna cause weakness in your medial rotation, or also called pronation. Medial rotation and pronation is the same, and lateral rotation and supination is also the same thing. Now, injury to the thoracodorsal nerve. Injury to the thoracodorsal nerve is going to injure one main muscle, which is the latissimus dorsi muscle. Now, weakness in the latissimus dorsi muscle is going to be like a big thing, because the latissimus dorsi muscle is like huge, and it's going to cause an issue in multiple functions in the arm. One of them being the adduction of the arm, extension of the arm, and medial rotation of the arm. And a way you can know if a person is having issues with his thoracodorsal nerve is the patient is going to have difficulty using crutches. And also you can have lifting body of the upper limb and transferring from a wheelchair. Now, coming to injury to your musculocutaneous nerve. Now, your musculocutaneous nerve is going to supply the flexors of the arm. And what are the flexors of the arm? You have the bicep brachii, brachialis, and your coracobrachialis. Now, the musculocutaneous is going to continue as then later is going to continue as the lateral cutaneous nerve. Now, the injuries that can happen can cause. Injury to your musculocutaneous nerve, where these muscles are affected, can cause multiple things. One of them being weakness for your elbow flexion, weakness to your forearm supination, and sensory loss to your lateral forearm. You need to know this. What supplies our lateral forearm is our musculocutaneous. So if someone has a loss of sensation in the lateral forearm, just always know it's musculocutaneous nerve injury. Now, why is our elbow flexion and supination not fully lost? Because our brachioradialis assists in flexion and our supinator muscle assists in supination. So you're going to have weakness in flexion and weakness in supination. However, it's not fully lost due to these two muscles. Okay, coming now to the injury to the axillary nerve. So an injury to the axillary nerve can happen from either two things, either from a fracture to the surgical neck of the humerus or a shoulder dislocation. The more high yield one is going to be a surgical neck fracture. However, you should also know the shoulder dislocation. Now, what muscles can be affected by this nerve injury? Your deltoid and your teres minor. Now, deltoid issue is going to cause the inability to abduct the arm beyond 15 degrees. You won't be able to abduct beyond 15 degrees due to deltoid muscle injury. And for the teres minor, you're going to have a weakness in your lateral rotation. Now, for the sensation, a way I memorized this, it's going to be the lateral part of your shoulder. So in here is the regimental badge area. You see where like military officers have like the badge on their shoulder. An injury to the axillary nerve is going to lose the sensation in that area. Now coming to the injury to the radial nerve. We already covered all of these in hand 1 and hand 2. We're just doing this for the sake of repetition and completion. So how can someone have an injury to the radial nerve? It's a fracture, it's a mid-shaft fracture in the humerus. The clinical features that can happen is wrist drop due to paralysis of the forearm extensor and the inability to extend the wrist and fingers. The sensory loss is going to be to the posterior forearm and the posterior hand. And the test that we mentioned earlier asks the patient to extend their arm, their wrist, while you have their hand on it, so it can be resistance. We mentioned all of this in hand 2. Now, coming to injury to the radial nerve again. Injury to the superficial branch of the radial nerve does not cause muscle weakness. Remember earlier we said we have a superficial branch and a deep branch. The superficial branch is just say cutaneous injury, cutaneous loss of sensation. And the cause sensory loss over the posterior hand is going to be in this area. You can see the red mark is going to be from the radial nerve. And we mentioned here in the circle, the coin area over here, there could be still some sensations over here because of the overlap of the median and ulnar nerve. Now, injury to the median nerve, the proximal part. We'll go over these really quick, however, we mentioned them in hand 2. The inability to flex the index and the middle finger, patient cannot make a fist. And the distal sign is going to be loss of thumb opposition causing ape hand. The ape hand is going to be in the picture in the next slide. And the sensory loss is going to be the lateral palm and the lateral 3.5 digits. Classic signs, benediction hand when making a fist, and ape hand due to the thenar muscle paralysis. And also a complete loss of thumb opposition. Here is going to be the distal signs for the injury to the median nerve distally, or you could also say carpal tunnel syndrome. Paralysis and wasting of thenar muscles, first and second lumbricals, is going to be complete paralysis and wasting of both of them. Clinical features, there is going to be complete loss of thumb opposition, giving us ape hand, And there's going to be a sensory loss over the lateral 3.5 digits, tingling and numbness in the median nerve distribution. And the test that we mentioned also earlier is you ask the patient to hold a piece of paper between his fingers, between his thumb and one of his fingers. The patient won't be able to do that if he has carpal tunnel syndrome because there will be no thumb opposition. Now, injury to the median nerve. In here, ulnar nerve, I'm sorry. Injury to the ulnar nerve is going to be medial epicondyle fracture. That if it's a medial epicondyle fracture, that means there's going to be an injury to the proximal part of the ulnar. So you're going to have issues. There's going to be signs of proximal and distal signs. The proximal signs will be weak rest flexion and radial deviation due to the loss of flexor carpi ulnaris, and you cannot flex your distal interphalangeal joints of your fourth and fifth fingers due to the flexor digitorum profunda is also going to be half of it, or like the ulnar half, because you have two halves. You have an ulnar half and the medial half. The ulnar half is going to be the part that's going to be paralyzed, and the distal signs are going to be paralysis of the hypothenar muscles and the third and fourth lumbrical muscles. Also, interosseous muscles is also going to be is going to go through paralysis, and you're going to have loss of finger abduction and adduction. Abduction was from dorsal interosseous muscles, and adduction was for palmar interosseous muscles. And you're going to also have a sensory loss over the medial 1.5 digits, the 1.5 digits being your small finger and half of your ring finger. The classic sign for this is going to be claw hand. However, I want you to know from here, it won't be complete claw hand because it's only the ulnar nerve that's affected. The complete claw hand is going to be from the lower brachial plexus. Lower brachial plexus palsy. Lower brachial palsy, I'm sorry. Injury to the ulnar nerve. So now, in the Hammoudeh bone fracture, there's only going to be an issue in the distal part of the ulnar nerve, not the proximal part. So you're only going to have the distal signs show. We already mentioned all these. The classic sign is going to be a claw hand, and the test is going to be you ask the patient to hold the finger between his index and the middle finger. If the patient cannot do that, that means his interosseous muscles are weak. Now, this is a really important picture, and it also makes stuff easier. A fracture in the surgical neck is going to cause damage to your axillary nerve. And the damage and the fracture in your mid shaft of the humerus is going to cause an issue to your radial nerve. And supracondylar fracture is going to be damage to your median nerve. And lastly, a medial epicondyle fracture is going to cause damage to your ulnar nerve. And we're going to start with questions. It's a pretty short lecture and very easy. During a fight, a man is stabbed in the lateral chest beneath the right shoulder. Physical examination reveals that the vertebral medial border of the patient's scapula projects posteriorly. So this is pretty obvious already. You could read the rest, but the answer over here is going to be B, long thoracic nerve, because this is basically explaining winged scapula. Following a road traffic accident, a young person was unable to initiate abduction at the shoulder joint. Initiation for abduction is going to be by the supraspinatus muscle, and the nerve that supplies the supraspinatus muscle is going to be the suprascapular nerve. Your friend had mid-humeral fracture, and his doctor treated him and told him that he's got a slight nerve laceration. Which of the following nerves is most likely affected? So we mentioned in the picture and in the slides, a mid-shaft fracture is going to be an injury to your radial nerve. And in an obstructed delivery, the physician pulled hard on the baby's upper limb, baby's upper limb, and delivered him. The born baby will most probably suffer from what? So pulling during birth is going to cause an injury to your lower brachial palsy, lower brachial plexus, mainly C8 to T1, and that would be a complete claw hand. I believe here it should be complete claw hand, but however, claw hand is correct. Okay, now we have clinical anatomy of the upper limb. Some stuff was repeated from upper limb nerve injuries. However, everything that was new I'm going to cover right now. I'd like to thank Zaid for doing the slides for me. Okay, now for shoulder bursitis. Shoulder bursitis is the inflammation of the shoulder bursa, and it's most commonly in the subacromial bursa. A bursa, so what is a bursa? Like, we need to know what is a bursa in the first place. A bursa is a small fluid filled sac that reduces the friction between structures, for example, like tendons or bones, during any movement. So now the pathology about it, in bursitis, the bursa becomes swollen and it thickens most of the time due to inflammation. An important point to like cover over here is that the subscapular bursa communicates with the shoulder cavity. And because of this communication, this is why we inject, we do an injection to this area to have an access to the joint. Now, what causes shoulder bursitis? Most of the time and most commonly is due to degeneration or inflammation of one of these two tendons, either supraspinatus tendon or long head of the biceps tendon. Another reason of shoulder bursitis happening is the repetitive shoulder movement can cause this irritation. Now, coming to the clinical features, patients usually come complaining of a deep aching pain in the shoulder. And this means that whenever they try abducting their shoulders, they're going to feel a pain, a very sharp pain, and this is going to be called painful arc syndrome. So once the patient goes between 40 to 120 degrees, this is going to be like a very high pain for the patient. A very sharp pain, I'm sorry. And this is how it's like, I guess this is like the difference between a healthy and a bursitis. This is like an infirm bursa. Also, do not forget that the needle is injected into the subacromial bursa to treat it. So impingement syndrome occurs when the space between the acromion and the head of the humerus becomes very narrow. And this narrowing is going to cause the supraspinatus tendon to be compressed. Especially this happens during abduction. You can see here, this is the supraspinatus tendon. And once the patient tries abducting, if the space is narrow, this is going to cause compression to the supraspinatus tendon. Now there could be 4 causes of this impingement syndrome, and this is the mnemonic. You're going to have AABB. A, arthritis, and another A, abnormal acromion shape. And for the B's, it's going to be bursitis, which we just covered just earlier, and biceptal tenditis. I'm sorry. Associated with painful arc syndrome, mostly in older people. This is why it's the same thing. So if a patient is having a pain once he's abducting his shoulder, and once the shoulder reaches between 40 to 120 degrees, this means the patient is going through painful arc syndrome due to bursitis or impingement syndrome. Impingement syndrome can cause, bursitis can cause impingement syndrome. Okay, now we have rotator cuff injuries and frozen shoulder. Now, rotator cuff injuries can have 3 different types, or multiple, but the types that we took are sprain, partial complete tear, and tenditis. Now, out of the 4 rotator cuff, because we have 4 rotator cuffs, we have supraspinatus, infraspinatus, teres minor, and subscapular. The one that is the most injured out of them, as I wrote here, is the supraspinatus. Now, because the supraspinatus is the most injured, abduction becomes very difficult, because we know that the supraspinatus is the thing that initiates abduction. That's why we have scapula and the deltoid muscle together. They help compensate for the loss of abduction. Now we have frozen shoulder. Now, frozen shoulder, also called adhesive capsulitis, it happens when the capsule of the shoulder joint, because it's called frozen shoulder, becomes inflamed and adhere to each other. So once there's shortening or inflammation or adhesion, we're going to get frozen shoulder. Now, tips to recognize a case of frozen shoulder: either old age, specifically above 50, because like this is where the age where people might get frozen shoulder, and progressively worsens over time. Like the longer you make it wait and without it being treated, the worse it gets, and it's seen worse at night. Now, separated shoulder. I'm pretty sure Ziad covered part of separated shoulder. However, I'm going to re-explain it. Separated shoulder is an injury to the acromioclavicular joint. And this injury to the acromioclavicular joint is going to involve the tearing of the the coracoclavicular ligament and the acromioclavicular ligament. What can cause this injury? Either falling directly onto the shoulder, contact sports, or riding accidents. So many things can cause shoulder separation or separated shoulder. And the injury seen, acromioclavicular joint dislocation with ligament tears. We just mentioned it over here. Severe cases equals to fracture or dislocation. So there could be some parts that are of the bone that are stuck to these ligaments. They can get fractured. And one of them is the clavicle. The clavicle may be fractured, and the most two common sites is either the middle or the lateral thirds of the clavicle. The site of the sites of scapula and acromion separation. You can see here the clavicle and the scapula. You have separation over here, this can be called separated shoulder. Now arterial pulses. You have two above the forearm and two below the forearm. Or not really below, it's like part of but you get the idea. So above the forearm, you have the axillary pulse near the armpit over here. It's going to be near the armpit over here. And then you'll have a brachial pulse just over here. And now the two most popular ones, which I think we've all tried feeling the pulse from there before. You have the radial pulse, which is over here, which I think is the most one that people use, and the ulnar pulse, because ulnar pulse is also a common one. However, I'm pretty sure radial pulse is the one that mostly people use because I think it's the strongest. It has the strongest pulse. And now this, I put it again because it was mentioned in the slides again. However, I don't think I need to re-explain all the nerves again because we know them by now. Very important to remember, carpal tunnel syndrome is involved with the median nerve, which causes compression of the nerve, which we know by now. And here are other cases that you can read on your own. However, everything that I mentioned earlier is what you should focus on. Now let's come to questions. A 69-year-old man has numbness in the middle 3 digits of the right hand and finds it difficult to grasp objects with that hand. He states that he retired 9 years earlier after working as a carpenter for 50 years. He has atrophy of the thin arm eminence. Which of the following conditions is most likely the cause of this of the problems in his hand? So, thin arm muscles should be really easy. It's going to be A, compression of the median nerve in the carpal tunnel. As a result of chronic stress associated with intense high school weightlifting program, a 15-year-old boy suffers an avulsion fracture of the greater tubercle of the humerus. In the ER, he displays difficulty initiating abduction of the upper limb. Which of the following muscles was involved in the fracture? So initiation of abduction should tell us that it's A, supraspinatus. Okay. This slide was repeated twice. Oh, wow. Okay. A 17-year-old boy comes to the emergency room after a hard fall onto the lateral aspect of his left shoulder during a high school basketball game. He complains of generalized pain during shoulder motion on physical examination. The distal end of the clavicle is prominent and distinctly palpable. Radiological findings confirm that the diagnosis of the severe grade 3 shoulder separation. Which of the following features is a component of this condition? So, this was mentioned earlier. And it's going to be B, torn coracoclavicular ligament, because this is not shoulder dislocation. So many people can confuse this and think this is shoulder dislocation. This is shoulder separation, and one of the ligaments is either acromioclavicular ligament or coracoclavicular ligament. A 30-year-old baseball pitcher reports sharp pain during abduction between 40 to 120 degree. So we mentioned this before. Is the pain arc syndrome, I think. The pain is localized to the superior lateral aspect of the acromion. Which structure is most likely inflamed? And the most common one we also mentioned is going to be the subacromial bursa. So most of the time, if a person is having troubles abducting and it's an issue with the bursa, 99% of the time it's going to be a subacromial bursa. And the slide was repeated again. Okay. A patient with claw hand deformity was wasting of the hypothenar eminence. A loss of the finger abduction and adduction. Which nerve is affected? Hypothenar, we should know it's going to be ulnar nerve. Okay, bones and joints of the pelvic girdle. Before I get started, I'd just like to thank Ziad for helping me make the slides for this lecture. let's get this started. Okay, now we have the bones of the lower limb. The bones of the lower limb is divided into an axial, is made up of axial and appendicular bones. The axial bone over here is going to be the hip bone, making the pelvic girdle. And for the appendicular, it was divided to three parts over here. You have the bones of the thigh, which is made up of the femur and patella, bones of the leg, which is made up of the tibia and fibula, and bones of the foot, which is made up of tarsus, metatarsus, and phalanges. Now, coming to the hip bone transmits weight from the upper body to the lower body. So our whole upper body, all the weight of it goes transmitted to our lower body through the hip bone. Once this bone joins the sacrum and the coccyx, we get a bony pelvis. Now, once you get a fusion over here of the ilium and the ischium and the pubis at the acetibulum, this is going to be the formation of our hip bone. We should know this from ERP, however, I'm just repeating it for the sake of knowing. And the head of the femur, as you can see here, is going to articulate with this acetibulum. Now, parts of the hip bone, I mentioned these already. You have the pubis and the parts of the pubis also. You have the ilium, and these are the parts of the ilium. I doubt you need to know these. And you have the ischium. Now, something important that I want you to know about the ischium has a tuberosity called the ischial tuberosity, which is the origin of the hamstring muscles. Now, you might not know what is hamstring muscles right now. I just want you to know that hamstring muscles make the posterior compartment of the thigh. However, we're going to get to know those even better once I explain thigh region. As you can see here is going to be the ischial tuberosity, and here you can see where these hamstring muscles are originating from them. Now, in this photo, I'd like you to focus on this thing where you have the greater trochanter and the lesser trochanter. Now, the greater and lesser trochanter make up this a line between them called the intertrochanteric line. Now, there's going to be some important things you need to know about them. However, I just want you to visualize them, so once we talk about them, it makes sense to you. So, avulsion of the hip bone. Now, before we start talking about what is avulsion of the hip bone, let's see the meaning of the word avulsion in the first place. So, avulsion means when there is a small part of the bone that is torn away from the tendon. This is going to be called avulsion. Now, avulsion of the hip bone, some stuff that can be avulged from the hip can be the anterior superior iliac spine or our anterior inferior iliac spine. If either of these two are removed, this is going to be called avulsion of the hip. Other things can be the ischial tuberosity, which is going to affect our hamstrings, or our ischiopubic rema. Now let's start talking about the femur. Now that we got the hip bone out of the way, now we have the femur. The head of the femur, now that we know, it articulates with the acetibulum. It is covered by hyaline cartilage, except of the fovoa capitis or something like that. And I want you to see over here, this is where it's going to be the area where there's going to be no hyaline cartilage around. The ligament of the head has an artery to the femoral head, which is critical for children more than adults. And this artery, by the way, is going to be called the obturator artery. However, we're going to get to that later. We have the distal part of the femoral head and the proximal part of the femoral head. Now, starting with the distal part of the femoral head, it receives blood from the medial femoral circumflex, and this medial femoral circumflex is going to then give us later on retinicular arteries, these retinicular arteries are going to supply the neck of the femur. And for the proximal part of the femoral head, they're supplied by a branch of the posterior division of the obturator artery. And over here is like everything that you need to know. Here is the femur, here is the neck of the femur, head of the femur, and this is where the articulation with the acetibulum is happening. And there's not much that I should cover over here. Okay, now the neck of the femur. Now the neck of the femur has an angle called the angle of inclination. This angle is usually around 125 degrees. And how is it formed? It's formed by a long axis of the femoral neck. And so over here, you see the femoral neck. This is a long axis of the femoral neck. And then it goes straight down, going along the shaft of the femur. This angle is going to be our angle of inclination. And this differs around age 6 or development of the femur. However, the range should be around 120 to 140. If you have a range over 140, is going to be called coxa valga, and it's going to look like something like this. And if it's under 120, over here it's like 90 degrees, it's going to be called coxa vara. Also, coxa vara is associated with femoral neck fracture. So if the femoral neck over here gets fractured, obviously the neck, the angle is going to decrease. And coxa valga is associated with the congenital hip dislocation. Now let's start talking about fractures of the femur. Now the femoral neck is mostly happens in old women. In the femoral neck fracture, by the way, it happens most of the time in old women with osteoporosis. Now the fracture of the neck causes shortness of the lower limb and lateral rotation. So if the question is given to you and they ask what happens during a fracture of the neck of the femur, it's going to be either shortness of the lower limb or lateral rotation. Now different types of fractures can either have no disruption to our blood supply to the head of the femur, or it can have an effect, and we're going to talk about these type of neck fractures. And hip replacement is the treatment for femoral neck fractures. Now, now we have two types of head and femoral neck fracture. We can either have intertrochanteric fracture or transcervical fracture. Now, for the intertrochanteric fracture, as you can see here, this is going to be between the greater trochanter and lesser trochanter. This does not affect our blood flow. You can see here, everything is fine and no blood vessel is affected. However, in the transcervical fracture, this is going to disrupt our blood flow, specifically our retinacular arteries, which branched off the medial circumflex artery, femoral artery, which came from the head of the femur. Now, this fracture can cause avascular necrosis if the blood through the ligament is inadequate. So if the blood going to the femoral neck is less and the patient already went through a transcervical fracture, the patient can go through avascular necrosis. Now, features of the femur. Now, the greater trochanteric serves as an insertion of the hip abductors. So this is all going to make more sense during thigh region. However, I'm going to read these for the sake of completion. The abductors are gluteus medius and gluteus minimus. This is for gluteal region. And for the rotators, you have the piriformis, obturator internus, superior, I think it's called gemellus, inferior gemellus, and obturator externus. And more features of the femur. Medial and lateral condyles are covered by hyaline cartilage because they take a part of the knee joint. So I'm going to mention in knee joint, however, I'll mention it already over here. You have the medial and lateral. I'm not sure which one is medial and lateral. However, they're covered by hyaline cartilage, so they can make the formation of the knee joint. Once they articulate with the tibia and the patella, and the knee joint is going to be made. This is going to make more sense once we cover knee joint. And the medial and lateral epicondyles for the attachment of muscles and ligaments. And the popliteus surface forms the floor of the popliteal fossa, which is part. The popliteal fossa is going to be where there's going to be the switch from femoral artery to the popliteal artery. Now let's continue talking about the fractures, which is the more important part of this lecture. You have midshaft fracture of the femur. So now, if there's a midshaft fracture of the femur, there's going to be the proximal parts are going to start getting flexed by the iliopsoas. You can see here the iliopsoas are going to start getting flexed, and it's going to be abducted by the gluteus medius and minimus. It's not really shown here. However, the distal part, so the distal part of the fracture, is going to get pulled. So one is going to get flexed, or you could say pushed up, and the other is going to start getting pulled, and the distal part is going to be pulled by the adductor muscles. So the abductor muscles are going to take the proximal, and the adductor muscles are going to take the distal part. Also, I'd like you to know that the distal part gets pulled proximally and medially. Now coming to the supracondylar fracture of the femur. This is the fourth fracture of the femur so far. So the supracondylar fracture, the gastromechanus is going to start rotating the distal fragments of the femur. This rotation and this rotation, so you can see here the gastromechanus is going to start rotating the femur. This rotation is going to affect our popliteal artery. Now fatal fat emboli. So when a long bone such as the femur gets fractured, there's going to be an intense contraction. So this needed like an intense contraction for this to be broken. Along with that, there's going to be fats that are going to be forced from the bone marrow, is going to be forced into the bloodstream. And if these fatal fats reach the pulmonary arteries, and this could be a fatal case for some people. Now, what is the patella? Now, patella is our biggest sesamoid bone in the body, and it's in the tendon of, and it's part of the tendon of the quadricep femoris. You can see here the quadricep femoris is going to give us a quadricep tendon, and then it's going to connect to the patella. And posteriorly, it is covered by hyaline cartilage. So the patella posteriorly, so it can articulate with the patellar surface of the femur. You need hyaline cartilage to help with this articulation. Now, what happens in patellar fracture? Quite similar to the our last fracture. The patellar fracture from a direct force leaves a small undisplaced fragment. So why does this happen? Didn't we say just earlier the quadricep tendon attaches to the patella? So a fracture in here, if they have a cut in half of the patella, this quadricep is gonna pull up the proximal part, making the distal part fall down. Now let's start talking about the hip joint. The hip joint is a synovial ball and socket joint, and it's between the acetibulum and the head of the femur. We've mentioned all this a lot of times. We should have this memorized by now. So what supplies the hip joint is supplied by the medial and lateral femoral circumflex and the superior inferior gluteal and obturator arteries. Have these arteries memorized for the blood supply of the hip joint. And now let's talk about the innervations. We've talked about the arterial blood supply. Now let's talk about the innervation. The hip joint is innervated by the femoral and the obturator nerves, the superior gluteal nerves, and the nerve to the quadratus femoris. Now the acetibular labrum. Now the acetibular labrum is a fibrocartilage rim that deepens the acetibulum. It's going to be around here. I'm pretty sure there was a better picture than this, but that's fine. It continues as the acetibular notch as the transverse acetibular ligament. Now articular capsule extends from the acetibulum and the transverse acetibular ligament. So basically, what is the articular capsule? You can see over here, this whole thing around it, you're going to have a capsule forming around it. And it's gonna make a line to the intertrochanteric line anteriorly, and distally is gonna go around the neck of the femur. Now anteriorly it carries the joint's major blood supply, which is the retinicular vessels. Over here it was mentioned to the intertrochanteric line anteriorly. So that means you're gonna have anteriorly the retinicular vessels because of the neck of the femur, along the neck towards the head of the femur. Okay, now coming to the ligaments of the hip and the femur, you could say. So starting off, you have the iliofemoral ligament. The iliofemoral ligament is the strongest ligament of the hip joint, and it limits two specific movements. It limits the hip extension and lateral rotation. And this femoral ligament is what helps us stand and contain posture without any muscular fatigue, without us getting tired. It's going to keep holding us. That's why it's the strongest ligament. Coming next, we have the ischiofemoral ligament, which supports the hip joint capsule posteriorly and limits the hip extension and medial rotation. And the pubofemoral ligament, it reinforces the anterior and inferior parts of the hip joint capsule, and it limits hip abduction and hip extension. So I want you to notice a common thing between these three. All these three ligaments, they limit the hip extension. That's something that could make it easier for you. So after you have hip extension memorized, you can then memorize lateral rotation for iliofemoral, medial rotation for ischiofemoral, and hip abduction for pubofemoral ligament. Now, ligament of head of femur contains the artery to the head of the femur, branches of the obturator artery. So this is where you're gonna have the obturator artery supplying the ball and socket joint, and this is where it's gonna come from. And the important blood supply to the femoral head in children. So this is like very important in children, especially in young age, because it's gonna be the artery that the children are gonna rely on. Later on, that's gonna change. Now, posterior hip dislocation. Most common hip dislocation usually comes from severe trauma. Classic mechanism, dashboard injury. So during a car accident, the most time a posterior hip dislocation happens is once the person during a car crash gets pushed dramatically against the dashboard. And that's basically it. For posterior hip dislocation, associated injuries. So what can happen once a person goes through posterior hip dislocation? So the person went through a car accident and he's hit the dashboard really hard. What can happen to him? He can either have a tear of the joint capsule and possible ischial fracture and a tear of the iliofemoral ligament. This is really important to know. Know these two, possible ischial fracture. However, I want you to know this the most, tear of the iliofemoral ligament. Because you can get given a clinical case of a person having a car accident and his posterior hip dislocating. Once the posterior hip dislocates, you need to know the iliofemoral ligament means it's ripped or teared. Now, what happens to the positioning of the limb is gonna become shortened, obviously, and medial rotation is gonna happen. Even though that somewhat does not make sense to me, because I'm pretty sure iliofemoral is what limits medial rotation. However, just memorize it, don't overthink it. And important complication, possible sciatic nerve injury. Now let's come to questions. An automobile accident, the patient's knee strikes the dashboard, which in turn pushes the head of the femur posteriorly out of its socket. So this is posterior hip dislocation. Which ligament is most likely ruptured by this posterior dislocation? As I said, posterior hip dislocation, always memorize it as iliofemoral ligament. Now, during a femoral fracture, which muscle causes the leg to shorten and rotate? Okay, and shortening during femoral fracture, you're going to have the iliopsoas. As we said, the iliopsoas is going to flex the proximal part of the femur, and this flexing is going to cause shortening. A 5-year-old child came with severe pain in the right hip. An X-ray of the hip joint showed avascular necrosis of the right head of the femur. Occlusion of a branch of which of the following arteries result in this condition? Notice that the child here is 5 years old. So that means it's going to be obturator artery. Always keep in mind, if the patient is young, always keep in mind that and he has avascular necrosis, 90% of the time it's going to be an issue with the obturator artery. If the patient is older, it's most likely going to be medial circumflex femoral artery. However, if the patient is young, the young patients are always going to rely on obturator artery. Last question. A 96-year-old woman slips and falls in the bathroom. She is unable to stand afterward and complains of severe pain in the right groin and hip region. On examination, her right lower limb appears shortened and externally rotated. Which of the following is most likely diagnosed? This is a question that we've basically repeated in one of the previous questions. It's just this time the question was reversed. Okay, now starting with the knee joint. So, lower limb osteology. The lower limb forms the parts of the appendicular. However, in here, when I wrote the divisions of the lower limb, I also mentioned the pelvic girdle, which makes up the axial, as you can see here. And then later on, we're going to start having our formation of our lower limb. We start off with the thigh region, which has the femur. And then with the leg region, you're going to have the tibia and the fibula. The patella is like in between both the thigh and the leg. And the foot is going to be made out of tarsals, metatarsals, and phalanges. Now, the main functions of this lower limb is to support our body weight, locomotion, and maintain balance. Locomotion is the movement of one place to another. Now, bones of the knee joint. Now that we know that the bones of the lower limb, now let's know the bones that make up our knee joint. We start off with the femur. The distal part of the femur articulates with the patella, as you can see here, and the proximal part of the tibia. Notice that the fibula over here does not articulate in the formation of the knee joint. Now, let's start talking about the distal femur and the patella. Now, the distal femur, as you can see here, has a lateral and medial epicondyles. Just similar to the humerus where it had lateral and medial epicondyles, it has the attachments for collateral ligaments and muscles. And then we have the popliteal surface, which is on the posterior part of the femur. It forms a part of the floor of the popliteal fossa. Now coming to the medial and lateral. Wait, where is medial again? Oh yeah, here, medial and lateral condyles, not epicondyles, but condyles. Once we reach the condyle region, this is where we're gonna have the articulation surface, articulation with the proximal part of the tibia, and this is gonna form us the tibiofemoral joint. However, we said that there's 3 bones involved. So we have a patellar surface in the femur, so which articulates with the patella and forming the patellofemoral joint. We also have an intercondylar notch, which is posterior, not anterior, which separates the medial and lateral condyles. It's also an important site for cruciate ligaments, such as the ACL and PCL, but however, we're going to talk about these more later on. Here is the proximal tibia over here and the proximal fibula. Here you have the articulation site between them, so we're going to talk about them over here. The proximal tibia forms the medial and lateral condyles. So just similar to the femur, we also have the medial and lateral condyles in the tibia, which also creates the tibial plateau. So this tibial plateau articulates with the femoral condyles, which is the medial and lateral condyles. And for the intercondylar eminence, attachments for an important ligaments, such as the cruciate ligaments and the menisci. Now, the tibial tuberosity is attachment site for the patellar ligament. Have this in mind because we're going to talk about the patellar ligament just soon in a bit. And then we have the head of the fibula. It articulates with the lateral part of the tibial condyle. As you can see here, the head of the fibula articulates with the lateral side. So know that the fibula is more lateral than the tibia. And it also forms a proximal tibiofemoral joint, and it mainly serves an attachment site for muscles and ligaments. Now articular surfaces of the knee. The knee has 3 articulations. It has 2 femorotibial joints. So I'll show you in the picture over here better. In here you have 1 joint over here and 1 joint over here. One articulation, another articulation here. Okay. And then we're gonna have another joint where you're gonna have 1 patellofemoral joint forming between the femur and the patella, and then you're gonna end up with the patellofemoral joint. The knee joint is mechanically weak. Yes, as you can see here in the photo, the joint looks weak, like it could easily break. That's why you have so many ligaments and muscles which help keep this joint stable. Now let's start talking about the movement of the knee. Now the knee joint is a hinge joint, so you're gonna have flexion and extension. And something that you need to know, that once the knee is flexed, you're gonna start having a limited rotation, medial and lateral rotation. So basically pronation and supination. So if you even try right now, if your legs are extended, you won't be able to rotate them. However, if you flex your leg, you'll be able to rotate your leg medially or laterally. This movement is called the screw-home mechanism. During full extension, the knee is locked. So you can see here, the knee gets fully locked, okay? And due to medial rotation of the femur on the tibia. However, to start flexion, you have this muscle over here called a popliteus muscle, which unlocks the knee from this median rotation by laterally rotating. So you see this is gonna pull the tibia and laterally rotate it, allowing for limited medial and lateral rotations at the knee joint. Now let's start talking about the Q angle. Now this Q angle is really important to know once you're diagnosing people with some certain diseases that we're going to talk about in the next slide. So, but first of all, let's know what is the Q angle. So the femur angles medially. Now, once we say medially, because some people might confuse it as medially with vertical, the femur angles medially. So it's going to start angling inward towards the body, where the tibia is vertical, it's just a straight line up. This angle between them is going to be called a Q angle. Now, in a normal alignment, body weight passes near the center of the knee joint and helps eventually distribute forces across the joint surfaces. And also, just to let people know, and in future diagnosis, if you have a female with a large Q angle, that's completely fine because their pelvis is wider than the male. So the Q angle being wider makes completely sense. So like if you see here, if the pelvis is larger, the femur medial angle is going to start moving a bit more lateral, which is fine. Now let's talk about the two different cases where the Q angle can be either decreased or increased. So if the angle is decreased, you're going to have a case called genovarum. Genovarum is going to be caused by an increased stress on the medial knee. So in the medial knee compartment, and its weight bearing shifts medially. Okay, and if the Q angle is increased, you're going to have a case called genovalgum. Genovalgum, you'll have weight bearing shifts laterally, increasing stress on the lateral knee compartment. Now, something about these two cases, that if it stays, it's going to cause knee instability, articular cartilage wear. So that means the articular cartilage is going to start slowly going away, or you're going to end up with osteoarthritis. And this mild forms may be normal in children. So in children, that's fine. However, if it stays later on, that could be abnormal. And persistent abnormal deformities can occur in conditions like rickets. I'm pretty sure rickets most of the time, or I think all the time, is going to be a genovarum. It's going to have this wide space between the legs. Now let's start talking about the knee joint capsule. The knee joint capsule is made out of two parts: an outer fibrous layer and an inner synovial layer. Now let's start talking about the fibrous capsule, the outer fibrous layer. The outer fibrous layer is thin and incomplete. So it's not fully closed and it's very thin. And it has an opening. Why is it incomplete? Because it has an opening allowing for the popliteus tendon to enter the joint. This is why we have the locking and unlocking, because of the popliteal muscle that allows it to unlock. Anteriorly, the capsule blends in with the quadricep tendon, and then you'll have the patella, and then the patella is going to make the patellar ligament. This is going to make more sense in the next slide, the slide after it actually, once we start talking about the patellar ligament. Okay, now the extra articular ligaments is made up, we have 5 extra articular ligaments, which help reinforce stability at the knee joint. So first of all, we have the patellar ligament, then we have the FCL, and then we have the TCL. Now, as you remember earlier, we had FCL is the lateral, because it was the more lateral bone, and the tibia is the more medial bone, so it makes the TCL. And then we have the last two ligaments, which are the oblique popliteal ligament and the arcuate popliteal ligament, which are found posteriorly, and we're going to talk about them more in details. Now let's start talking about the patellar ligament. Now the patellar ligament, you need to know that it's a continuation of the quadricep tendons, and they provide an anterior support to the knee and helps maintain the patellar alignment. So you can see here, the quadricep tendon is going to continue on and give us then later on the patellar ligament. Now for the collateral ligaments, you'll have a TCL, or also called medial collateral ligament, or you'll have an FCL, which is the lateral collateral ligament. That's basically all you need to know. Just one of them is medial and the other one is lateral. As you can see here, because you have the fibula over here, that means there's going to be lateral collateral ligament. And because the tibia is over here, you're going to have the medial collateral ligament, or also TCL and FCL. Now we'll start talking about the posterior ligaments. On the oblique popliteal ligament, it's an expansion of the semi-membranous tendon. So you could say it's similar to the quadricep tendon giving us the patellar ligament. For the oblique popliteal ligament, it's an expansion of the semi-membranous tendon. And we're going to know this tendon in the thigh region, inshallah. And then we're going to have the arcuate popliteal ligament, which arises from the head of the fibula. Now let's start talking about the injuries of the collateral ligament. Now, the medial collateral ligament is going to come from a lateral force coming from the side. It's going to be injured by a valgus force. Now, how did I memorize this? The valgus force has an L in the middle. So the way I memorized it, this L means that there's going to be a lateral force from the side. This lateral force on the side is going to push onto the side and is going to rip our MCL or our medial collateral ligament. And this can also injure our medial meniscus, which we're going to talk about soon. And for the lateral collateral ligament injuries, it's going to be basically the opposite. From medial force or varus force, since there is no L, the way I memorized it, it's going to be a medial force. It's going to push onto the medial side of the knee and it's going to rip our lateral collateral ligament. Now we talked about the extra-articular structures. Now let's talk about the intra-articular structures. Now these intra-articular structures are really important to know. You have the cruciate ligament, which is located in the center of the knee, and they make a cross, an X shape. And this is so you could probably tell from here, this is going to be the ACL, and this is going to be the PCL. If you want to know what does ACL and PCL means, ACL is the anterior cruciate ligament, and the one in the back is going to be the posterior cruciate ligament. And these help with anterior and posterior stability and knee rotation. For the menisci, it's going to be a crescent-shaped fibrocartilage attached to the tibia. You can see here, these are going to be the meniscus, the two meniscuses over here. And what's the purpose of these? Is for shock absorption. So when someone jumps, these meniscus absorb this shock, and they distribute sometimes the forces. Now, let's start talking about the cruciate ligaments, starting with the anterior cruciate ligament. So, the anterior cruciate ligament, let's talk about its attachment first. So, it's a posterior medial part of the lateral femoral condyle, and on the tibial side and the tibia side, it's an anterior intercondylar area. You need to memorize this, or even by looking at the picture over here, you can be able to tell. And for the function, it prevents anterior displacement. Because it's in front, it prevents you from the knee, you could say the tibia being forward, going, protruding forward. And it also limits hyperextension. And it stabilizes rotational movements. That's what cruciate ligaments do. Now, let's talk about anterior cruciate tear. So now that we know it's at the anterior side, the causes could be sudden pivoting, twisting, or hyperextension. Especially hyperextension, most of the time is what it happens, or sudden pivoting actually, is where you can have an ACL tear. What will you find? It's going to make a sudden pop sound, and it's going to cause knee instability. Now the two tests, we have a Lashman test, which is more sensitive, and we have an anterior drawer test. This is an anterior drawer test where it's going to be protruding more forward. Now we have the posterior cruciate ligament, PCL, and the attachments for it on the femur. It's going to be attached in a medial femoral condyle, and then the tibia is going to be a posterior intercondylar area. You can see here, this is the posterior view, and this is going to be our posterior cruciate ligament. Now, what's the purpose of it? Basically, the opposite of anterior cruciate ligament. Is going to prevent posterior displacement of the tibia, and is going to prevent hyperflexion. So ACL is for hyperextension, and PCL is for hyperflexion. Oh yeah, and just know, when you're walking down a hill, for example, the thing that helps stabilize us and not basically flexing our knees every time we start going down is our PCL. Now, what happens in a PCL? Most of the time, it happens from a dashboard injury. So now we know dashboard injuries can come from two things. It can cause two things. Either a PCL, or it can cause a posterior hip dislocation. However, for this lecture, let's focus on the PCL tear. And fall on a flexed knee. So if your knees are flexed and you fall on it, this is going to cause hyperflexion, and your PCL is going to tear. And the findings are going to be pain, swelling, difficulty bearing weight, and posterior sag sign. But this posterior sag sign is also one of the tests that you can use to see if there's a PCL tear. And just opposite to the ACL, you do a posterior drawer test where the tibia is going to start going inward rather than outward. Now that we mentioned the cruciate ligaments, now we're going to talk about the menisci. Now, the menisci is a fibrocartilage plate on the tibial surface, as you can see here. It helps deepen the joint surface and help absorb shock or shock absorption in general. And it's thicker at the periphery than in the and thinner in centrally. So basically on the sides you can see often they look thick. However, if you look at them in the center and the middle, it's going to be thinner. And what are they attached to? At the ends, they're going to be attached to the intercondylar area of the tibia, and the outer margins is going to be just the joint capsule. Now let's differentiate between the medial menisci and the lateral menisci. So the medial menisci is going to be a C shape. You can see it looks like a C over here. And it's less mobile due to the attachment to the tibial plateau and the MCL. So this is why, because of this less mobility, it's going to make it more prone to injury. Because if you have like a sudden movement on it, even though it's less mobile than the lateral menisci, is going to cause like more injuries to happen. However, for the lateral menisci, it's more circular. It's not really a C shape. It's like about to be a full circle. And it's more mobile than the medial menisci. And posteriorly, it's related to the popliteus tendon. Now that we mentioned all of these ligaments and menisci and all of those and cruciate ligaments, now you have a case where it's called unhappy triad. This unhappy triad is when you have the rupture of three structures. The first structure you'll have is your ACL. Your ACL is going to be torn. Actually, it's going to be in the front over here. It's an anterior view. And the other rupture is going to be our medial collateral ligament. And then you're going to have a rupture, here you can see it. And you have a medial meniscus. These three can be injured. It's not even that rare to happen. The common mechanism is going to be a valgus form. As we said, you can see an L in here. That means it's going to be a lateral force coming, which is going to rip these three structures. Why the medial meniscus is injured? Because it has a firm attachment. So you could be asking yourself, the ACL and the TCL rupture makes sense. However, the medial meniscus does not make sense once you have a valgus force, because the MCL is attached to the medial collateral ligament. Once it ruptures, the medial meniscus can be ruptured with it too. And the clinical features is knee instability, pain, swelling, and severity ranges from sprain to complete tear. Now let's start talking about the synovial membrane. The synovial membrane lines all non-cartilage surfaces of the knee joint. And you need to know, it reflects around the ACL and the PCL. So as you can see here, it reflects around them. However, it excludes them from the synovial cavity. Why is this important to know? If it excludes them from the synovial cavity, this means that during an injury, these structures won't be able to heal after an injury, because the synovial is what gives us the nutrients. It's what gives the knee joint its nutrients. So, relation to the joint capsule, you have the ACL and PCL. So they are intracapsular, however, they're extrasynovial. And that was it for knee joint. Now let's start doing the questions. Which structure serves as the distal attachment site for the patellar ligament? Okay, this is easy. We mentioned it earlier. It's going to be the tibial tuberosity. Which structure is most commonly injured as part of the unhappy triad in addition to ACL and TCL? Because MCL or TCL, you could also call it, is injured, you'll have the medial meniscus, which is attached to it, also rip. The ACL and PCL are described as the extrasynovial because, we just said it in the last slide, that they lie outside the synovial cavity. And now we have the thigh region. The thigh region is going to be our last tense lecture, and then we'll have the gluteal region, which is going to be one of our short lectures. And let's start with thigh region. Now the fascia of the thigh is made up of two fascias. It's going to be made up of a superficial fascia and a deep fascia. Or it also can be called sometimes the fascia lata. Now the superficial fascia is continuous with the anterior abdominal wall, and that's all you need to know about the superficial fascia. However, for the deep fascia, there's three important characteristics about it. One of them being it forms the iliotibial tract, and I'll show you how that looks like in the next slide. And it has an opening below the inguinal ligament called the saphenous opening, where it has a great saphenous vein running through it. And Here, as you can see, it transmits the great saphenous vein and lymphatic vessels. And this saphenous opening is then going to be filled with loose connective tissues, and these loose connective tissues are going to be called the cribriform fascia. And lastly, we have 3 facial intermuscular septa, and actually I'll show it to you over here. First of all, this is the iliotibial tract, and this is the saphenous opening over here. You can see where the great saphenous vessel runs. And then we have the 3, what do you call it again? 3 intermuscular septas. Now, in the 3 intermuscular septas, you're going to have an anterior compartment over here, which is going to be where you're going to have your flexor muscles. And then you're going to have a medial compartment where you're going to have your adductor muscles. And then you're going to have a posterior compartment where you'll have your extensor muscles. Now that we finished the fascia, now let's start talking about the muscles, starting with the anterior muscles of the thigh. The first 2 muscles that we're going to talk about are going to be the iliopsoas and the sartorius muscle. The iliopsoas muscle, what you need to know, is a sheath flexor of the hip joint. Oh, something else I wanted you to know, these anterior muscles, they're all going to be innervated by the femoral nerve. The sartorius muscle is going to flex the hip and the knee joint. So what I want you to know that these 2 muscles only allow for flexion. Both of them flexes the hip, and the sartorius flexes the knee joint. You need to know these actions because it's going to be really important to know later on. And you can also see here, the sartorius starts laterally from the anterior superior iliac spine, and is going to then run medially to the side or the medial side of the tibia. So the quadricep femoris is basically, from the name you can see quadricep. That means it's going to be made up of 4 muscles. These 4 muscles are part of the anterior compartment, and we're going to start with the rectus femoris. The rectus femoris also flexes the hip, however it extends the knee. So these quadricep femoris, they all extend the knee. And they're also innervated by the femoral nerve because they're part of the anterior compartment. And then you have the 3 vastus. You'll have a lateral, medial, and intermediate. All these 3, their function is they extend the knee. And you can see the intermediate is going to be just behind the rectus femoris. And then you'll have the medial and the lateral. Now you'll have the pectinus. The pectinus is part of both. Well, it's not really both, but it's kind of both. The anterior and medial compartment. And because it's part of both the anterior and medial compartment, the anterior side is going to be innervated by the femoral, and the medial side is going to be innervated by the obturator nerve. And its function is to flex and adduct. So the flexion comes from the anterior, and the adduction comes from the medial. Now that we finished the anterior compartment, now let's start talking about the medial muscles. So we're going to start off. I don't know why the picture here is not showing. However, it was a picture of the gracilis. I'll fix that later once I upload the slides. Now what I need you to know, all medial muscles, their main function is for the adduction of the hip, and they're all innervated by the obturator nerve. So all these muscles that we're going to see, they're going to be for the sake of adduction of the hip and obturator nerve. However, the gracilis, something I wanted you to know, it looks similar to the sartorius. I don't know why the picture is not showing here. It looks similar to the sartorius, however, it's gonna run from medial to medial. So sartorius is gonna run from lateral to medial. However, for the gracilis, it's gonna run from medial to medial. For the obturator externus, this is how it's gonna look like, and it adducts the hip joint, and it's innervated by the obturator nerve. Now we have 3 adductor muscles. First of all, let's talk about the 2 adductor muscles, which is going to be the adductor longus and the adductor brevis. The adductor longus is also going to be for the adduction of the hip joint, and it's innervated by the obturator nerve. Now the adductor brevis, I don't know if you need to know this, however I just put it just for the sake of completion. It lies deep to the pectinus and adductor longus muscle, so it's basically behind the adductor longus, and it's also the same functions, adducts the hip joint, and it's also innervated by the obturator nerve. The adductor magnus is an interesting muscle. Why is it interesting? Because it has 2 portions. Similar, you could say it's somewhat similar to the pectinus. However, the adductor magnus is a much more obvious idea that it has 2 portions. You have an adductor portion, which is on the medial side. It adducts the hip joint, and it's innervated by the obturator nerve. And we have a hamstring portion, and these hamstring portions are part of the posterior muscles. So that means they're going to be for the sake of extending the hip joint, and posterior muscles are innervated by the tibial nerve. And here are the images for the adductor muscles. You have the adductor longus over here, adductor brevis, which is going to be behind the adductor longus, and then you have the adductor magnus. You'll have the medial side, and you'll also have a posterior side portion. Okay, now we're going to talk about the posterior muscles. Now the posterior muscles, we'll have the hamstring muscles. The hamstring muscles are made up of 3 muscles. Now before we get to the biceps femoris, because it also has an interesting idea, it's just similar to the adductor magnus, let's start talking about the semitendinous and semimembranous. Now the semitendinous, it extends the hip joint, and the semimembranous also extends the hip joint. If anything, they have the exact same functions. They both have the exact same functions, and they're also both innervated by the tibial nerve. For the biceps femoris, you'll have 2 parts. You'll have a long head and a short head. The long head will have all the same functions as the short head. So it's basically long head, same functions as the short head, plus the extension of the hip joint. And it's innervated by the tibial nerve. However, for the short head, it's going to be innervated by the common fibular nerve. And the semitendinous is not showing over here either. However, these are the images, so you can be able to maybe tell between the origin and the insertions. Now that we finished the muscles, let's talk about the femoral triangle. The femoral triangle is a very high yield concept, and I very suggest you guys to memorize everything in this slide right now. So the femoral triangle, it's how do you form the femoral triangle? Let's start off superiorly. Superiorly, you'll have the inguinal ligament. And once you run laterally, you're going to have the serratus. So you remember earlier we said serratus runs laterally, then medially. In the femoral triangle, it's more proximal up, so that means it's going to be lateral. And then you're going to have, medially forming the femoral triangle, you're going to have the adductor longus. Now for the floor, if you are for the floor of the femoral triangle, you're going to have the iliopsoas. If you start from lateral to medial, you're going to go from iliopsoas, then pectinis. And so you'll have 2 muscles making the floor. And for the contents inside the femoral triangle, going from lateral to medial, you're going to have the femoral nerve, femoral artery, femoral vein, and femoral canal. And this femoral canal contains deep lymph nodes and vessels. So the way I memorized it, I used the mnemonic just navel. Navel, you're going to have nerve, artery, vein, lymph nodes, which is in the femoral canal. Also, the femoral canal can also be known as femoral rings, just so you don't get confused in the exam. And what I wanted to mention here, that the structures under the inguinal ligament that we need to know now, if you go from lateral to medial, you're gonna have the iliopsoas muscle over here, which also we know makes the floor of the femoral triangle. And then you're gonna have the femoral nerve, then femoral artery, then femoral vein, and then you're gonna have the femoral ring, or it was earlier called the femoral canal. Now that we finished the femoral triangle, let's talk about a femoral hernia. Now, femoral hernia passes below the inguinal ligament. And through the inguinal ligament is going to run through the femoral ring, or we said earlier over here, it's going to be called the femoral canal. This hernial sac can protrude through the saphenous hiatus into the superficial fascia. So, just earlier, we said, I'm pretty sure you can see it over here. In the femoral triangle, you're going to have this, the saphenous hiatus, where you're going to have this great saphenous vein running out of it. However, in femoral hernia, once it goes below the inguinal ligament, it can protrude through that, and you'll see this protruding through, and it's going to be pushing onto the superficial fascia. Note that the femoral hernia is more common in females. Now, what we need to know, which is a very important concept, a very important idea, is an aberrant obturator artery. Now, aberrant means abnormal. So it's going to be an abnormal obturator artery. Now, obturator arteries usually they branch off the internal iliac artery. However, for some people, it could branch off the inferior epigastric artery. This case is very benign, and the patient's body can work completely fine. However, if someone has a femoral hernia during surgery, the surgeon might not know this. And if he does not know this, the patient can cut the obturator artery, and this is going to cause interoperative death. And it's also called corona mortis because it means like the crown of deaths. Now let's start going to the vessels of the thigh region. Starting off with the femoral nerve. The femoral nerve is the largest branch, is the largest lumbar of the lumbar plexus. So you have a lumbar plexus, and the largest branch of it is the femoral nerve. And what does it innervate? And then you have 4 branches of the femoral nerve. You'll have the muscular branch, which supplies the anterior thigh muscles, which we know by now. All anterior thigh muscles are supplied by the femoral nerve. And you have also an articular branch, which supplies the hip and the knee joint. You also have a cutaneous branch, which supplies the skin of the anterior thigh, which makes total sense. And then you'll have a terminal branch. So the femoral nerve is then going to end up as the saphenous nerve. This saphenous nerve is a cutaneous branch, and it supplies the skin and the fascia of the anterior medial knee, so like around this area of the knee, and is going to run through the leg to the foot. Now we have the obturator nerve. Now the obturator nerve, you need to know you have an obturator canal. And this canal, you're going to have the obturator vessels and nerve running through it. However, we're talking about the obturator nerve, so let's talk about the branches of it. You have a muscular branch. Just earlier we talked about the medial compartment is all supplied by the obturator nerve. So it's going to supply the medial thigh muscles. And you're also going to have an articular branches which supply the hip and the knee joint, similar to the femoral nerve. And then you have a cutaneous branch which is going to supply the medial thigh. So basically, our main focus for the obturator nerve in the thigh region, it supplies the medial portion. Skin or muscle it's supplied by the obturator nerve. Now the sciatic nerve usually divides in the distal posterior thigh. So that means the sciatic nerve, just earlier we said the posterior portion is mostly innervated by the tibial nerve. This tibial nerve is branched off the sciatic nerve. This sciatic nerve also gives off the common fibular nerve, which supplied, what did we say earlier? The short head of the bicep femoris. Now, to differentiate between them, the tibial nerve mainly supplies the posterior thigh muscles, posterior leg muscles, and the sole of the foot. For the common fibular, it supplies the anterior compartment of the leg, so the area below the thigh, and the lateral compartment of the leg, and the short head of the bicep femoris. Now, for the common fibular, it's going to be explained better, I think, by Omar in his lectures, because it mainly focuses on that region. Okay, for the cutaneous innervations of the thigh, the picture is not showing here, so I'll have to go out. So, for the femoral nerve, you're going to have over here the femoral nerve supplying the anterior part of the thigh. And for the obturator nerve, so this is basically a repetition of what we just said. The obturator nerve is going to supply the medial part of the thigh, and then the lateral thigh is going to be a continuation of the femoral nerve. So we know the femoral nerve is going to continue as a lateral femoral cutaneous nerve, which is going to give us the supplying of this area of the thigh, and also this area. And then the posterior femoral cutaneous nerve is going to give us the posterior side. Okay, now coming to the femoral artery. The femoral artery is the major arterial supply for our thigh, and it's a continuation of our external iliac thigh. So this is how I want you to know. You have the external iliac artery, which is going to give off our femoral artery. This femoral artery is going to continue until it reaches the adductor hiatus, and is going to give us our popliteal artery. However, let's focus on our femoral artery area. So the femoral artery is going to give us 5 main branches, okay? It's going to first of all give us the superficial circumflex artery, the superficial epigastric artery, external pudendal artery, and the profunda femoris. The last branch of the femoral artery is the descending genicular artery. However, for the profunda femoris artery, it's going to give us 4 different arteries. This means the profunda artery is one of the most important branches of the femoral artery. It's going to give us the medial femoral circumflex. If you remember from earlier, it's going to then give us the retinicular arteries, which supply the neck of the femur, as you can see here. And then you're going to have the lateral femoral circumflex, and then you're going to have 4 perforating arteries. By the way, this is just a continuation of the medial femoral circumflex. You only have 3 branches of the profunda. Now, this is the slide got repeated for some reason. Let's continue. Okay, now for cardiac catheterization, the femoral artery is a common access site for the cardiac catheterization. So that means once you want to get a catheter and pass it through until it reaches the heart, you want it to start from the femoral artery. So once you start from the femoral artery, you're gonna reach the external iliac, and then after you reach the external iliac, you're gonna reach the common iliac, then to the aorta, and then finally to the left ventricle. Now that we finished the femoral artery, we have the obturator artery. The obturator artery, unlike the femoral artery, is a branch of the internal iliac artery. It enters the thigh through the obturator canal, and it has a clinical importance. In 80% of the individuals, the artery of the head of the femur arises from the obturator artery. That means the obturator artery is a main supply for the hip and the femur. And what you need to know is that it's the main blood supply for the femoral head in children. Now, in adults, if preserved after femoral neck fracture, it may reduce the risk of avascular necrosis of femoral head. So now start talking about the veins, the veins of the thigh. So the veins of the thigh, you'll have the femoral vein. So it's going to be going the opposite side of the femoral artery. So you're going to start off the popliteal vein, and then you're going to start going up, and then you'll get the femoral vein over here, and then it's going to become the external iliac vein. So it's a reverse process. And then you'll have the tributaries. It's basically branches of the vein. So first of all, you'll have the deep vein of the thigh, which is formed by the perforating veins. And then you'll have the great saphenous vein, which drains into the medial leg. So here you'll have the great saphenous vein, which is going to drain into the medial leg. And then you'll have the small saphenous vein, which drains into the lateral leg so here, I think it's going to be somewhere over here. The small saphenous is going to come and it's going to drain into the popliteal vein. And then this popliteal vein is going to then later on become the femoral nerve. Now, the great saphenous vein is superficial veins are located in the subcutaneous tissue, formed from the dorsal venous arch of the foot. So basically, the photo here is not working. However, the dorsal venous arches are going to go all together and form the great saphenous vein. And then, so what's the course of the great saphenous vein? It's going to ascend on the medial side of the leg and thigh, and it's going to pass anterior to the medial malleus and posterior to the medial condyle of the femur. The drainage and clinical relevance of this, it empties into the femoral vein below the inguinal ligament. It's just, as you can see over here, it's just below the inguinal ligament, and is commonly used for a coronary artery bypass. So what is a coronary artery bypass grafting? If someone's artery is not working, you can take a piece of this great saphenous vein and you can replace it with it. Lastly, we're going to talk about the varicose of the veins. So the venous blood flows into the superficial veins, and the venous valves, they prevent backflow. So the reason why, because the veins in the foot and the leg, they're very low down. So it can easily get stuck like down here. That's why you have valves to prevent backflow. However, if the valves are not working, it's going to start making the blood flow back into the superficial veins. Remember this, superficial veins. And this is going to increase venous pressure and cause the veins to become more dilated, tortuous, and enlarged. And some clinical features of this is going to be brown skin pigmentation, skin ulceration, and skin softening changes. Now let's do questions. The hamstring muscles are innervated by which of the following? It's easy. Posterior compartment we know is tibial nerve. And then which of the following muscles form the lateral floor of the femoral triangle? We have the lateral floor. So in here you'll have two floors, the iliopsoas and the pectineus. However, the most lateral one is going to be the iliopsoas. And then a patient has weakness when flexing both her thigh and leg. Which of the following muscles? So which muscles cause both flexion in the thigh and the leg? That's going to be the serratores. And then lastly, a 65-year-old woman presents with a painful swelling in her right groin that developed after lifting heavy objects. The swelling has been diagnosed as a femoral hernia. What is the femoral hernia located in the relation to surrounding anatomical structures? So in here, it was mentioned just earlier in the slides, it's going to be in the medial to the femoral vein. Why did we say here in the medial to the femoral vein? Because it's going to, as you can see, in the femoral triangle, we said we have four structures. You have the nerve, then the artery, then the vein, then the femoral canal. The femoral canal is medial to the femoral vein, and the hernia is what the hernia forms at the femoral canal. And now we're gonna start with gluteal region. This is gonna be the last lecture of this video, and inshallah Amr is gonna continue the rest of the lectures. Okay, now we're going to talk about the ligaments of the gluteal region. We have two major ligaments, which are the sacrotuberous ligament and the sacrospinous ligament. The sacrotuberous ligament, from the name, you could be able to tell where does it originate from and where does it insert to. You're going to have it's going to come from the sacrum, and it's going to then join to the ischial tuberosity. That's why it's called sacrotuberous ligament. What does it form? It forms the inferior border of the lesser sciatic foramen. And now you have the sacrospinous ligament. The sacrospinous ligament, again, from the name, is going to go from the sacrum and then it's going to connect to this ischial spine over here. And why is this important? It separates the greater sciatic foramen and it also separates it from the lesser sciatic foramen. Now that we talked about the sciatic foramen, let's see what does each one contain. The greater sciatic foramen, it has multiple structures running through it. One of them being the piriformis muscle, which is going to be really important to know. And you also have the sciatic nerve, the pudendal nerve, and you also have the internal pudendal arteries and veins leaving the greater sciatic foramen, going to the lesser sciatic foramen, which we're going to see just now. And you also have the posterior femoral cutaneous nerve to the obturator internus, and nerve to the quadratus femoris. Now, for the lesser sciatic foramen, the structures passing through it, you're going to have the pudendal nerve and internal pudendal vessels entering the perineum, and you're going to have the obturator internus muscle and this nerve. Okay, now let's start. Now that we got these out of the way, now let's talk about the muscles of the gluteal region. So let's starting off with the gluteus maximus. The gluteus maximus is the primary extensor of the hip. So the main function of this muscle is the extension of the hip. It's important in multiple things, such as climbing stairs or standing up from a seated position. And it's innervated by the inferior gluteal nerve. Have this known because it's going to be important once we start talking about the clinical aspect of this muscle. And then we'll have the tensor facial latae. It tightens the facial lata and the iliotibial tract, and it assists in the hip stabilization. It's innervated by the superior gluteal nerve, and the other two muscles that we're going to talk about is the gluteal medius and gluteal minimus, which are also innervated by the superior gluteal nerve. However, their function is for the abduction of the hip. So the gluteus maximus is for the extension, and the gluteus minimus and medius are for the abduction of the hip, and they stabilize the pelvis during walking. Note, the gluteus minimus is located directly underneath the gluteus medius. So you can memorize it as like an order. You'll have the gluteus maximus, and then the medius, and then right beneath the medius, you're going to have the minimus, as you can see here in this photo. And now we're going to talk about the piriformis. Now, the piriformis is a very important muscle, and you need to know, and it has multiple things that you need to know about it. Now, what's the main function of the piriformis? Its main function is to laterally rotate the thigh, and it divides the structure entering and exiting the greater sciatic foramen. As you can see here, this is the piriformis, and this is going to divide, and this is the greater sciatic foramen, and it's going to divide the stuff exiting from it. Above the piriformis, you're going to have the superior gluteal nerve, and below it, you're going to have the inferior gluteal nerve. That's how you can differentiate between them. But below it, obviously, you can see here from the spaces, the inferior and below the piriformis, you're going to have a lot more structures above the piriformis. From these structures, you're going to have the sciatic nerve, the pudendal nerve, internal pudendal vessels, posterior femoral cutaneous, nerve to the obturator internus, and nerve to the quadratus femoris. And it's innervated by the S1 and S2 nerve roots. You have this memorized because it's quite different from the other muscles. Now, since we talked about the piriformis, let's talk about piriformis syndrome. Now, piriformis syndrome is caused by the inflammation or spasm of the piriformis muscle. This spasm and this issue with the piriformis can compress a very important nerve, which is the sciatic nerve. We just said earlier, running below the piriformis, you're going to have the sciatic nerve. So it's going to produce similar pain to something called the sciata. In some individuals, part of the sciatic nerve, the common fibular nerve, it passes through the piriformis muscle instead of below it. So, right, we said the sciatic nerve, it runs below. However, in some individuals, it's going to run right through it, piercing through the piriformis. And the hypertrophy of this muscle, so in these patients, once they have hypertrophy in this muscle, it's going to cause a lot of pain because you have the sciatic nerve running through it. Okay, now we're going to talk about the supinators of the hip. Okay, now for the supinators of the hip, you're going to have 4 muscles. You're going to have the superior gemellus and the obturator internus. These 2 muscles are innervated by the same nerve, which is the nerve to obturator internus. Here, so you think of it this way: the nerve to obturator internus are going to be the 2 most superior ones, which is over here going to be the superior gemellus and the obturator internus. And for the inferior 2, you're going to have inferior gemellus. In here is written inferior gemellus, however, it's going to be the quadratus femoris. Here you'll have the quadratus femoris and not the inferior gemellus. I'm going to fix that later. And the nerve that's going to be supplying these 2 are going to be the nerve to the quadratus femoris. So have this memorized. So obturator internus, on top of it you're going to have the superior gemellus, which is going to be supplied by the nerve to obturator internus. And over here, you're going to have the quadratus femoris, which you're going to have on top of it also the inferior gemellus, which these 2 are going to be supplied by the nerve to the quadratus femoris. Now we're going to talk about the nerves and the gluteal regions and injuries. So the superior gluteal nerve is going to innervate 3 main muscles. Okay, you're going to have the gluteus medius, gluteus minimus, and the tensor facial lata. What also I'd like to mention, between the medius, the gluteus medius and gluteus minimus, you're going to have the superior gluteal artery running between them. Now let's talk more about the superior gluteal nerve. So the superior gluteal nerve is going to, so any hip surgery, posterior hip dislocation, anything like that, why they focus on posterior hip dislocation? Because most of these cases is going to happen because of a posterior hip dislocation. So this can affect the superior gluteal nerve. And what's going to happen here? So let's say you're standing on your left foot. However, once you're standing on your left foot, let's say your left superior gluteal nerve has been damaged. What's going to happen, your right side of your pelvic area is going to be pushed downward. So although the right side looks there's something wrong, however, it's going to be the left side that's going to be it's going to be the left nerve which is going to be the one that has the trouble. This is going to be called Trendelenburg sign. Now for the superior gluteal nerve injury, it's the exact same thing that I just explained in the previous slide. Here you can take the example. So let's say your right superior gluteal nerve is damaged. Once you stand on it, you can see here you're going to find the pelvic region is going to be going downward. That means that the right gluteal region, the right superior gluteal nerve is damaged. So you could say it's not the same, it's collateral. Okay, now we're going to talk about the inferior gluteal nerve. And if you remember earlier, the inferior gluteal nerve innervates the gluteus maximus muscle. And this nerve, it runs along with the inferior gluteal nerve. Now, why is this important? The inferior gluteal nerve the causes of the injury of the inferior gluteal nerve is going to be posterior hip dislocation or surgery in this region. So again, posterior hip dislocation can cause either inferior gluteal nerve injury or superior gluteal nerve injury. Now, the clinical signs of this, because it's made for extension, because the gluteus maximus is for extension, if you're in a seated position and you're trying to stand up, it's going to be harder to do. And same thing in here, going up the stairs is also going to be a difficult task to do. Now coming to the sciatic nerve. The sciatic nerve is the largest nerve in the body. Even I think if you saw it in the cadavers, the nerve was it was a very huge nerve. So what did we say earlier? What does the sciatic nerve? It passes below the piriformis muscle. We also said it could also sometimes run through the piriformis. However, in the normal case, it runs below the piriformis muscle. What does the sciatic nerve contain? One of these is going to contain the common fibular nerve and the tibial nerve. And these two are usually separate in the popliteal fossa. So it's going to run, and then as soon as it reaches the popliteal fossa, where we're gonna reach the leg region, you're gonna have the common fibular and the tibial nerve separate. It supplies the posterior portion of the muscles, which is the hamstring portion. They just know from what we said in thigh region, the posterior portion is mostly supplied by the tibial nerve, except the short head of the bicep femoris, which is going to be supplied by the common fibular. Now let's talk about the sciatic nerve injury. Now, what can cause the injury to the sciatic nerve is improper placed gluteal injection and posterior hip dislocation. So these three nerves that we just talked about, all of them can be caused by injury to these nerves can be caused by posterior hip dislocation. Now, I'd like to focus on this because this is quite high yield. Improper placed gluteal injection can cause this sciatic nerve injury. What do I mean by this? So you can see here you have a green spot over here. The injection should be placed over here. Anything outside that can damage the sciatic nerve. So it's going to be in the upper quadrant to the lateral side. Now, the clinical signs of this sciatic nerve injury is going to be weak hip extension and knee flexion. And other signs you can see on this patient is foot drop. Foot drop means you're going to have a lack of dorsiflexion. And flail foot is going to be lack of both dorsiflexion and plantar flexion. So that's the difference. You need to know the difference between them. Foot drop is going to be lack of dorsiflexion. Flail foot is the lack of both dorsiflexion and plantar flexion. Now, let's start with questions. 67-year-old patient was given a course of antibiotic by gluteal intermuscular to avoid damaging the sciatic nerve. The needle should be inserted into which of the following? So, to avoid damaging the sciatic nerve, what did we say? It needs to be in the gluteal region, above, in the upper quadrant, lateral side here. You can see it needs to be in the upper quadrant, lateral side. So the answer here is going to be D. A 75-year-old lady had difficulty standing up from a chair. So the patient is struggling to go from a seated position to a standing up position. We said in this case is going to be the muscle that's going to be involved is going to be gluteus maximus. A patient comes to the orthopedic clinic with a waddle gait. On examination, it was found that there was a weakness and abduction of the right hip. There was damage due to which of the following nerve? So abduction is gonna be done by which muscles? By the gluteus minimus and medius. And which nerve supplies these? We said earlier is gonna be the superior gluteal nerve. A 24-year-old visits the clinic 3 months after she was shot in the superior gluteal region. When she tries to lift her left leg, the contralateral part drops. Which nerve is most likely affected? It's the same question just as earlier. Going to be superior gluteal nerve. And lastly, for the last question, a 40-year-old woman had difficulty standing up from a chair. We just did a similar question to this earlier. It's going to be the inferior gluteal nerve. And that was basically it for part 2 of the MSK crash course. I really hope this helped you in any way possible. And inshallah, you guys all do really good in your finals, inshallah. And now Omar is going to continue his part for part 3.